name's Colette and I'm one of the advanced practice leads with Cumbria County Council, and myself and Kelly, who's here as well, will be facilitating today's session. Do you want to introduce yourself, Kelly?
Yeah. Right, thanks, Colette. Hi, I'm Kelly Short. I'm the designated nurse for adult safeguarding for Morecambe Bay CCG safeguarding team, and I have MCA in my portfolio as well. Thanks, Colette.
Thank you. So in terms of today, we're here to look at adult B, and the aims of the session are to look at the SAR criteria, the Safeguarding Adult Review criteria, the learning and recommendations from the review, and to make sure that people are aware of the Cumbria Safeguarding Adult Board website and resources that are contained on there as well. Now, it's important for us to sort of say that, you know, it could be quite an emotional, challenging, mentally exhausting session, just by the very subject nature of what we're going to be discussing. And just a reminder that your usual routes of support from your team managers and your teams are there. But Kelly and I are also quite open to follow-up discussion if you need us as well. And the details for how to get in touch with us will be at the end of the presentation. But just, you know, be mindful of yourselves in all of this as well, because it's not always an easy subject to be looking at. So I'm just going to hand over for Kelly, and she's going to explain a bit of a background around safeguarding adult reviews.
Yeah. Thanks, Colette. So majority of you will be aware that the Care Act 2014 gave a statutory responsibility to all safeguarding adults boards to arrange a safeguarding adults review when the case involved an adult who had care and support needs. Now, it doesn't matter whether or not those care and support needs were being met by the local authority or not. And those safeguarding adult reviews would be whereby they meet the criteria of an adult who has died or who has been seriously harmed, and the board or professionals knows or suspects that this is a result from abuse or neglect. And there's reason to believe that there's concern how members of multi-agency teams and organisations work together in order to safeguard the adult. So for the purpose of the definition and the criteria around significant harm, I think it's important to just specify that significant harm is defined as life-limiting incident, including psychological harm as well, from which where there is no recovery. So those are the kind of areas which has to be met in terms for the criteria to be met in terms of the Safeguarding Adults Review. So what is the purpose of the Safeguarding Adults Review? Well, essentially it's to prevent future deaths or serious harm in the future for further population within Cumbria for ourselves. It's a process where we can look at promoting effective learning and improvement action to prevent those future deaths and prevent future harm. The aim of the review should be to learn lessons from a case and to make sure that those lessons are applied to future cases by all agencies, again within Cumbria for the purpose of this review, to prevent similar harm from occurring. It's an opportunity to look at multi-agency working and to work through any blockages and challenges which agencies might have faced within a particular case. So then we can work together to strengthen that multi-agency partnership working. And also it's an opportunity to review any challenges and look at the effectiveness of any policies and procedures that we have in place, and to look at the impact of them actually in practice, whether that's good or bad. To look at any service improvements or development needs, which obviously we'll be looking and discussing as we go throughout today's session for Adult B. And essentially to look at whereby we've got any good practice which we can share across the agencies and services that we're all working within. So can you, onto the next slide, thank you, Simone. So in terms of requesting a SAR, so people may not be aware of how to do this and how this process works. So we've already made reference to the specific criteria in order which needs to be met in order for a safeguarding adult review to be accepted and looked into. So it's really important that within your own agencies and your own organisations that you seek support from your safeguarding adult lead in the completion of a SAR referral, and really give clear information of how and why it meets that criteria. And I know that sounds simple, but we have experienced over the years some poor quality referrals which have come into the system, and it's taken a lot of unpicking to really identify of how and why the criteria has been met. We've had other instances where agencies aren't aware that people within their own organisation have actually made a safeguarding adult referral, and they're not aware of it. So again, there needs to be some quality assurance mechanism within your organisations ahead of making the referral into the Cumbria Safeguarding Adults Board. So any organisation who has worked or has been working with an adult can make a referral into the system. It might be a professional who's independent from the Safeguarding Adults Board, or it could be a member of the board who makes those referrals. Or it could be the individual concerned themselves, or the family members, or other interested partners, such as the coroner. And we do see a wide range of referrals into the system. And if we can just move on to the next slide, please, Colette. So what we have got here, and again, you may not be already familiar with the Cumbria Safeguarding Adults Board website, but on the website there is a professionals page whereby you can access guidance and support around the safeguarding adult referral process. And the referral form is also embedded on that particular part of the website. Really useful. If you haven't had exposure to it before, just have a play around. There's lots of good resources and tools on there to help support if you do have a particular case which you want to consider submitting for a review. I think we're over to yourself now, Colette.
Yeah.
To the next slide. Thank you.
Thanks, Kelly. What we're going to do now is just play a very brief video, and it'll give you what's a very basic overview of Adult B's situation. And it really will just scratch the surface of what was going on for Adult B, but hopefully for those of you that aren't familiar with the case, that it'll give you some overview that'll help make the rest of today make sense. So I'm hoping this will work. Kelly, if you don't get sound, will you let me know? Okay, thank you. Adult B tragically sustained a significant brain injury during an accident as a child. This resulted in her having a learning disability and limited ability to communicate with others. She lived at home with her family as a child and moved into supported living as a young adult, residing with the same provider for over 25 years. Practitioners and carers who cared for Adult B recalled how she liked singing and dancing and would enjoy having her hair and nails done at the day centre she attended. Adult B had a long medical history, which included low body weight and esophageal reflux. Medication and food supplements were prescribed to manage this. However, on occasions, Adult B would refuse food and spit it out. Carers who knew her well became increasingly concerned about a decline in her weight, psychological and physical health. Communication became difficult, even for those who had known Adult B for years. During the last 2 to 3 years of Adult B's life, there was a period of decline, during which time there was significant multi-agency involvement in her care. However, the review noted a number of delays during which there was deteriorating behaviour and increasing frailty, which caused carers and family concern. Sadly, Adult B died in hospital, aged 52 years old, 36 hours after a surgical procedure for the insertion of a feeding tube,
which is in place to allow for artificial feeding and improve her nutritional intake. The review highlighted a number of key themes as areas for learning.
Okay, and it's those areas for learning that we're going to focus on today. We are also going to look at some of the positives that came out of Adult B's case as well, because it's really important that we show that balance and we can learn from the good practice that happened. If you haven't already read Adult B, the learning brief is a couple of pages long, and it will give you a summary of the main report's findings. And if you click onto this link within the presentation when you get it, it should take you straight there. And it is, as I say, well worth a read to get the full context about what's been going on for Adult B. And we're going to go through each of the themes individually, but I'll just hand over to Kelly and she'll explain that further.
Brilliant, thanks. So the panel and its members agreed the scope of the review should include a time period between July 2016 and November 2017, and it was agreed that the purpose of the review would be to determine a number of things. So firstly, to determine whether decisions and actions in the case comply with the policy and named services of the Adults Board. To examine interagency working and service provision, which Adult B was open to explore the effectiveness of information sharing and working relationships between agencies and within agencies as well. We were going to look at the continuity of care and care coordination throughout the timeframe which was identified for Adult B, and to review and consider if roles and responsibilities of the key professionals were understood by others. It's going to give us an opportunity to scrutinise the timeliness of interventions for Adult B and the quality of assessments which were undertaken for her. The report and the review and what we'll look at today will explore whether principles of making safeguarding personal were applied in this particular case, and if any learning from the case about the way professionals and agencies work together to safeguard Adult B were appropriate, and to identify any actions which the Adults Board and its partners to promote learning and support to improve systems and practice in the future can be picked out. So when I've mentioned that, the key themes from the report include these particular areas. So a recurring theme throughout various SARs that have been published over the years is around mental capacity and best interest decision making. So we're going to explore that further. We're going to be looking at the nutrition pathways for underweight adults and around capacity, how we manage difference of opinions, and if we could just go on to the next slide, please, Colette. We've already alluded to the continuity and coordination of care and hospital discharge planning, assessment of funding of care needs, and how we support staff. So these were the main key areas which came out of this particular review for Adult B. Thank you, Colette.
Thank you. Okie dokie. So the first one that we're going to look at is the mental capacity and best interest decision making. And as I'm sure you're all aware, the Mental Capacity Act applies to anybody working in social care, health and other sectors who are involved in the support and treatment of people. There are a number of agencies involved with Adult B, and it's clear that the agencies were completing and recording capacity assessments and best interest decisions. The timeline demonstrated that there was an understanding from professionals of the necessity for a best interest decision when making significant decisions on behalf of Adult B, and that's really positive. Unfortunately, not all practitioners were involved with these meetings. Either they weren't invited or they weren't able to attend them. And it was expressed at the learning event. There's a learning event that goes alongside the SAR. The outcomes for the best interest meeting were not always fully understood, or they were not always shared with all involved, particularly between professionals. And the resulting lack of timescales and ownership applied to action plans might have contributed to treatment delay and frustrations alongside caring for adult B. Sorry, I'm just click onto there. Lovely. The other area that came out for adult B was around the use of independent mental capacity advocates. And the Mental Capacity Act suggests that in complex cases, an IMCA should be in place, particularly for these reasons up on the slides, around serious medical decisions, people who are unbefriended, and where the local authority is proposing longer term accommodation or NHS accommodation. Now, with adult B, the social worker had discussed the referral to an IMCA with adult B's mum, and she was in agreement with this. There is one reference to a request being made to the IMCA service, and that was a request to attend the best interest meeting, but nobody was able to attend from that service due to short notice. And the information available suggests that there was no further IMCA involvement from that point. Now, adult B's mother was able to provide some support in decision making, but she was unable to attend meetings regularly as she had other full-time caring responsibilities. She had telephone contact with adult social care about supported living issues, and she was invited to a best interest meeting held at the hospital. And it was that meeting where consent for treatment was discussed. It would have been best practice to involve an IMCA to work in partnership with adult B's mum in relation to her best interest, to ensure that independent oversight was available in this case. This may have strengthened decision making and prompted timely implementation of agreed plans and supported both adult B and her mother. Another one of the themes in relation to mental capacity that came out from adults B was around the recording of best interest decisions. Now we're all here from lots of different organisations, and we will all have our own forms and ways of recording within them organisations, and it's not realistic to expect that everybody has the same form across Cumbria with all organisations. But what is important is how the Mental Capacity Act is captured within our recordings, and all best interest meetings should reference the specific checklist as outlined in the Mental Capacity Act, and that includes these factors here. And these need to be clearly documented, whatever format it is that you're using to record, as it helps give clarity and rationale to decision making and for information to be shared clearly between all involved. This link here, the MCA checklist for practitioners, is a link to a resource that you may feel beneficial to print out and carry around with you, or just to have as a point of reference. And it outlines all of these factors here that we need to be taken into account in order to make sure that our best interest decisions are robust and consistent across organisations. We're over to Kelly.
Okay, so the next part of the discussion which we're going to present is around the patient pathway for underweight adults who lack capacity. So if we just pop onto the next slide, what I'm going to do is, and apologies, I am going to refer to some notes because we're going to walk through what we feel was really significant and the timeline of events for adult B, just again to give you a flavour of what was happening throughout the last, year of this lady's life. So please forgive me, I am going to refer to my notes because it's absolutely key, some of the information within this element. So historically, we've already alluded to adult B had a long medical history, which included low body weight, which had required food supplements to her diet since 2005. She was known to have esophageal reflux and vomiting since 1998 and had been taking medication for this. Now, adult B could present with behaviour which challenged staff, but they were able to manage this and provide appropriate levels of care. So communication with adult B was difficult, but for those who knew her well and who'd worked with her over a significant period of time, they were able to understand and support her needs. But then we get to 2015 and concerns were starting to be raised by the GP and adult social care the GP and adult social care by a support team at the beginning of 2015. And during this time, adult B was continually refusing food or spitting it out. And she had started to decline in her psychological and physical health, which we've already alluded to. There were frequent contacts with the GP throughout her life and intense involvement from the community learning disability team and speech and language therapists and dietitians from May 2015 onwards. So then we go to April 2016. Adult B was weighed regularly, and this was recorded in care records at the home. Her weight in April 2016 was 40 kilograms, so 6 stone 4. But this continued to fall. In August 2016, her weight was at a lowest level, which was 28.4 kilograms, so 4 stone 7. And during this time, adult B was weighed almost weekly, and her weight fluctuated between 32 and 33 kilograms generally over a period of a few months. And in June 2016, the named GP, the psychiatrist, learning disability nurse, all had meetings and contacts with adult B in this time frame around her weight and a health situation which was continuing to deteriorate. This resulted in a GP referral being made in June 2016, following which a gastroenterologist appointment took place, and they did attempt an endoscopy, but adult B couldn't tolerate it. So records show that PEG feeding was being considered at this time. So that's June 2016. September 2016, there was a discussion by the GP, the Community Learning Disability team, as to whether or not a PEG feeding tube to support nutritional needs should be explored. Now, some members of the MDT felt that adult B wouldn't tolerate, and she may pull it out, or she might not be well enough to cope with the actual procedure. It was identified at this stage a best interest meeting should be coordinated. I want to take you between September 2016 and spring of 2017. So the issue of the PEG feeding tube was identified and is requiring discussion by several professionals between that period of time. The hospital serious incident report identifies that a referral was made for adult B in October 2016 for a PEG insertion. Can we just move on to the next slide, please, Colette? So then we're now in February 2017. So there were further delays for adult B in making an appointment. This doesn't happen until February 2017, and a further delay then takes place because of an admission date for the procedure for the endoscopy didn't occur. So we're now in May 2017. I'm sure you're starting to get a bit of a picture of what's happening here. A best interest meeting to agree a care plan for the PEG feed doesn't come about until May 2017, by which time adult B's an inpatient in hospital for abdominal pain. The root cause of the delay in adult B's admission for the relevant investigation and treatment was around the lack of robust processes for the admission of requiring an endoscopy under general anaesthetic. The best interest meeting held in May 2017 included a junior doctor, community practitioners, her support team, her mother and her brother. The GP and social worker weren't actually party to these discussions or invited to the meeting, and it's not entirely clear as to why that was. It would have been best practice for all the practitioners to get together to have the opportunity to share the information and to contribute to that best interest view. But as a result of the best interest meeting in 2017 in the May, it was agreed that the insertion of the PEG should be facilitated and the artificial feeding would improve nutritional intake. At that time, it was also agreed for dental treatment to take place as well. Adult B unfortunately had a number of teeth which had also decayed, just to pop that in into the discussion. Unfortunately, the consultant gastroenterologist wasn't available for a further 6 months, who'd agreed the initial best interest plan for the insertion of the PEG feed and requested for a junior colleague to coordinate the care plan. We're now in July 2017. The PEG feed didn't take place as planned, and adult B was assessed by a separate consultant gastroenterologist in July 2017, and at this point there was a view that the feeding tube wasn't necessary. The decision was due to feeling that her eating and her nutrition had improved and that she was gaining weight with an improved presentation, albeit she was still significantly underweight at this time. August 2017, a CT scan took place under sedation when adult B was admitted to hospital, again presenting with abdominal pain. The findings of the scan suggested that there wasn't anything seriously wrong with adult B to account for a weight loss. And she was actually discharged with there was a discharge plan which did take place and was agreed. However, they didn't have an outcome of for those findings. The decision to progress to a PEG feed wasn't recognised until adult B's mother made a formal complaint to the hospital in August 2017, and that was around the delay of care and treatment for her daughter. This is 8 months after the first agreed best interest meeting had taken place. So as part of the hospital's complaint process, adult B's mother met with the original gastroenterologist, who agreed to put the initial best interest meeting plans into action. And at this point, adult B's weight was 30.8 kilograms, so 4 stone 11. We're now into November 2017. Adult B was admitted for the insertion of the PEG feeding tube and the removal of the 3 teeth, which had decayed. By the time steps were taken to carry out the procedure, obviously adult B's frailty had increased and the risks were discussed with adult B's mum. A routine pre-op anaesthetic assessment prior to admission hadn't occurred, so as it would have been expected to. Adult B is therefore seen on the day of the surgery by the anaesthetist, who, following discussions with the mother, agreed that a DNA CPR form was to be put in place. Following the operation and after making initial good post-op progress, adult B became unwell and then she sadly died the following morning, 36 hours following the surgery. So I thought it was really important that you gained an understanding of kind of the delays in the care and treatment, you know, from the initial assessments and discussions to a death. And if we just move on to the next slide, Colette, that would be really helpful. And what happened, significant number of areas for improvement have been identified as part of that timeline and lessons to be learned. So areas for improvement consist of a number of areas, a number of points. What's really important to say at this point, you know, it cannot be said with any certainty that if a PEG had been inserted earlier, that it would have altered, obviously, the outcome. However, from the point of initial discussions regarding the possibility of the PEG feed being inserted and the support of nutrition to the point of adult B actually having it inserted, it took over a year, during which time adult B had become more frail and significantly underweight. It should also be stated that it was a really challenging and complex situation, and you know, everybody does appreciate that. It might be the case that even with the most cohesive of care plans, adult B may not have gained weight or improved her physical health status. However, the report does identify a number of gaps in her care, and the massive impact of not having a coordinated approach for health for adult B is one of the big areas which obviously comes out of the report. So in terms of the areas for improvement and the clinical pathways, what we're looking for is guidance which promotes early intervention, which includes goals, timescales, and appropriate action to ensure that time between somebody becoming chronically underweight and the use of a feeding enteral feeding tube should be reduced, as quickly as possible to alleviate malnutrition and when it's in the adult's best interest. And we've got documents and guidance such as the NICE guidance, which does provide the support and the direction of what actions should be being taken in terms of best practice. This identifies the recording of weights on a graphic adult weight chart, which weren't in use. It would have provided a much better picture where her weight was flat, that changing ever so slightly, and that overall picture is part of the clinical monitoring process to aid medical diagnosis. The other areas there around the learning disability hospital liaison nurse. So initially in adult B's early contact with the hospital services, there weren't a hospital liaison nurse available to assist with understanding of what those reasonable adjustments for adult B should have looked like. That individual, for having that particular post in place, would have helped to coordinate the inpatient care and treatment plans. At the time of the first gastroenterologist appointment, there was a learning disability liaison nurse in place within the trust. However, the systems and processes at that point for notification, tracking and support for this vulnerable patient group was still very much in its infancy. The reviewer has been looking at the national programme for learning disability hospital liaison nurse, and it is best practice for hospitals to have this particular practitioner in place to ensure that complex cases and best interest decisions are safely met in a formal and timely way, and it helps to aid and share information in a much more streamlined way. And then in terms of the effective coordination for this lady, I'm sure everyone can already see the gaps in the care which were provided. Adult B was seriously underweight, and throughout this time period, it was frequently reviewed. There was shared anxiety regarding adult B's weight amongst professionals, and this was also reflected amongst the care staff who were involved with adult B. They were becoming really frustrated that the felt weight gain, however minimal it was providing false optimism with professionals, and that staff were feeling, professionals felt she was getting better, even though she was still significantly underweight. Obviously, the slight weight loss had the opposite effect on what the carers felt, and I've just mentioned their frustration there around that. The concerns and the focus by all involved with adult B on whether weight was going up or down may have contributed to those involved being unable to holistically explore reasons for being seriously underweight and the complex contributory factors that indicated adult B required more effective nutritional management. And again, research tells us that people with a learning disability are more likely to have a poor diet and be more underweight, or on the flip side, obese, than members of the general population. And that comes through the study and the work from the LEADER, which is the Learning Disability Mortality Review Programme. Being underweight and malnourished raises the risk of serious health problems and can directly affect the quality of life of an individual. Now, assessment and the management of people who are underweight and have a learning disability is highly complex and challenging and requires a robust multi-agency approach with regular planned reviews to evaluate the success of actions that have taken place and to review the future management plan for this particular vulnerable cohort. So the result of the best interest meeting, which took place in May 2017, where the need for the insertion of the PEG feeding tube to facilitate the artificial feeding and improve nutritional intake was absolutely key. And unfortunately, you know, the consultant wasn't able to carry out that plan, and other members of the team took over that responsibility. So there was just a slight disconnect there. So it's acknowledged that the department was resource and reliant on locum consultants to see the patients at the time adult B was being seen in the hospital. There was then the added flaw of the routine pre-op anaesthetic assessments prior to admission not taking place, which we've already alluded to is best practice and should be standard practice within the organisation. And there was a significant number of professionals involved in the care of adult B. They did all go to great lengths in order to try and meet her needs. But unfortunately, it was that inconsistent and lack of continuity which didn't help and support the case in this instance. It was fragmented and the services didn't fully come together for a consensus view of what was best. Some professionals felt isolated and frustrated about what could then be done next to escalate the situation. And that brings us nicely into Colette's management of difference of opinion slide.
Thanks, Kelly. As you'll have heard from what Kelly was explaining there were a number of occasions where different services held different views around the health issues and care arrangements for adult B. For example, some professionals at the hospital felt that adult B's deterioration in health and behaviour was most likely due to a mental health or learning disability, but the supported living service at adult B's home and the community learning disabilities team felt that the deterioration was due to the physical condition and associated pain. The difference of opinions about adult B's health persisted with both the hospital and community staff. And there does not appear to be an understanding or agreed consensus about the actual cause of the weight loss and the poor eating. The carers at the supported living service at the learning event explained that they felt they'd not been listened to in their views and their opinions not valued. This was understandably very frustrating for them, given that they'd supported adult B for a long time. And it was said that most professionals would spend significantly shorter periods of time with her than they would. A safeguarding referral was raised in August 2016 as the carers became worried about her deterioration and presentation. At this time, adult B was too unwell to attend daycare services for several days. Though she was being supported at home, the care team were not allocated any additional resources to support her needs. The referral for the safeguarding was closed by adult social care 3 days later with no further action. The manager of the supported living service was informed the adult social care team was satisfied that the current arrangements were meeting needs and that a safeguarding investigation was not required. It's the opinion of the SAR reviewer that the safeguarding referral should have progressed to stage 2 of the safeguarding model, the 7 stages. The expectation should be that information is gathered about the concern by consulting other agencies in undertaking a risk assessment. It's felt that this was a missed opportunity to explore the safeguarding concerns at this stage and to call a multi-agency strategy meeting with an independent chair to consider in detail the issues and differences of opinions and to agree a multi-agency plan. It's highlighted in the report that professionals need to be clear when dealing with complex cases where there is a difference of opinion, how and where they can escalate their concerns in a timely manner. Lovely. So some really good suggestions there. There's a couple more on here and we'll add yours onto this slide as well from your discussion. But yes, the escalation guidance, really positive that that's come up within your discussions. The report for adult B did highlight that the Cumbria Safeguarding Adult Board didn't have a clear escalation policy for managing difference of opinion for safeguarding issues, and this has now been addressed. There is a clear escalation policy, and it was suggested within the report that actually that escalation policy would have supported the social worker and the other staff involved with any frustrations around decision making. And it resulted that some of the frustrations from the social workers' point of view was where they did things like discussing with their legal team to see whether the court of protection route would be appropriate. However, no legal action was taken in this case. The escalation arrangements would have allowed for the matter to be dealt with by senior managers across all partner agencies. So as we say, there is an escalation guidance, and within the slides you will find a link. So this link here will take you directly to that for your reference. But it's split up into 4 main sections. So stage 1 is to discuss with the other professionals and practitioners involved. Stage 2 is escalation to your line manager. Stage 3, escalation to service or senior managers. And for stage 4 is the resolution by the Cumbria Safeguarding Adult Board. So that is a tool to have as well, tool for your back pocket really. If you are finding yourself in a situation like this, that's another avenue that you can lean on for some sort of support and guidance and a clear structure across partner agencies. And then we're going to go on this afternoon to look at some more of the themes from the session. So I'm just going to hand back over to Kelly, who's going to go through the next section.
I thought I got away with that today. I was on mute, and apologies. Going on to the next slide, please.
Oh,
right. Brilliant. Oh, next slide.
Yeah.
This one? This one, brilliant, thank you. Right, so this slide is to kind of grab your attention at the moment. So we're talking around continuity, coordination of care and that hospital discharge planning. So here you will see many people involved, many contacts, and the stuff in the bubble, in the pink bubble, are words from individuals which came out through the practitioner learning event. So just going to leave that on whilst I just talk through a couple of those different elements at the moment. So we've already numerous times we've reflected on the importance of continuity of care. And in this case, the lack of coordination between health professionals across the hospital and also within the community. So during this particular review period for Adult B, we've already said she remained extremely underweight, and this was subject of grave concern amongst all those individuals who were caring for her, whether it was their community learning disability team, the consultant, the families, dietitians, all those different people all had grave concerns around this lady. Regular weighing was attempted and regular contact around her low body weight, poor general health, poor eating and refusal of medications were made with the GP and the out of hours services to address all these numerous issues which we've got there. This accumulated to at least 52 GP contacts in that reporting period that we're looking at the moment. 18 different GPs were involved with this lady within that reporting time frame. 45 calls were made to out of hours GP services. There was an identified named GP lead for Adult B, but they were only involved in 13 of these particular contacts, which we've got here on the screen. And whilst all this was happening, obviously Adult B's care and needs continue to deteriorate. Are we all right to pop onto the next slide, please, Colette? So within the report, we've looked at what those identified issues were and where improvements have been made in terms of the continuity and coordination of care within Adult B, to show some of the learning and improvements and how we've responded to some of those recommendations. So GPs, they know which patients they're responsible for, and the practice team also help patients to reconnect with different services or systems when they're experiencing discontinuities or fragmented care generally. So they're the key. GPs are absolutely key in coordinating some of this practice. GPs also take responsibility for ensuring that patients with long-term conditions, multiple morbidity or complex problems receive comprehensive, personalised, holistic and coordinated care. That's within, what's expected within their particular role. And they may take the lead coordinating role or may collaborate with colleagues in practice teams or from other services to act as the care manager or coordinator. They have got clear lines of accountability and leadership. That's not saying that doesn't come with the support of other agencies, linking in, but generally that's some of those expected roles from our GP colleagues. So there was a named GP for Adult B. There was a GP with that overarching responsibility for that continuity of care regarding Adult B. However, they weren't always available, obviously, in all these multiple contacts into the GP practice and the services. The coordinator, the main GP, wasn't always available when the need arose due to the local working practices, and the GP then, as a result of all the different contacts, not always being fully aware of all the different issues which were being presented. So each GP, and we've mentioned there were 18 of different GPs involved, were always reacting to Adult B's changing healthcare needs, which resulted in lots of different medication changes, but there were minimal evidence to suggest that there was a proactive formal planning which included goals, aims and timescales for Adult B in this particular case. We've said around the different contacts into the out of hours services, which amounted to 45 of those contacts for the period of review, and that was generally around her not taking a medication. The range of information provided often left the support team looking after her on a day-to-day basis, feeling confused, feeling frustrated, and that then meant there were additional contacts the following days after a medical professional had been involved to actually into the community learning disability teams for further advice and support. So you can understand how it was getting really messy, really complicated, and the care team didn't know where to go with this. So what's happened as a result, and in our discussion which we've just had in our room, there is now in numerous areas across Cumbria, within the different ICC areas, they do hold weekly or monthly complex case meetings with the multidisciplinary team to ensure that adults with complex needs are reviewed on a regular basis to avoid issues such as treatment delays. So that's a really good improvement. That is showing to be some really good best practice, to identify that particular task. It would, and it definitely is contributing to improving coordination of care and having a positive impact on individuals within those areas. So this should be shared if it isn't already working in your particular areas, and you've got the ability to influence, for such meetings to take place, then definitely something to take back to your areas. Another area of improvement has been the introduction of hospital and GP summary care records, which can be accessed by out-of-hours services to assist on that ongoing management and treatment and care planning, which was an issue in this particular case. There was lots of different systems involved, and not everybody could appropriately access the different systems within health. So since Adult B's death, work has taken place in primary care to implement a health action plan, which is widely being used to improve information sharing and care coordination as well. The health action plan developed by the GP gives an overview of the individual's health needs, appointments and screenings. Now, I'm not sure whether that's just in one particular area. Again, it would be interesting to explore that a little bit further across Cumbria to see which areas have adopted this particular model or something similar, and if not, again, to influence and share some of that best practice across the system, really. And we've already touched upon the IT systems, and lots of the practitioners in this particular case relied on letters and emails and telephone calls to share information. This was really time consuming for those practitioners involved, and in cases where there is constant change due to the different demand, you know, the increase in demand, and also it's not really practical again. So hopefully the improvements which have been implemented would help to support and alleviate those particular issues from happening again. In terms of the acute trust and reasonable adjustments, hospital passports was in place with the care provider in the home where Adult B was residing. They used to manage her information and communication, what she used to like, dislike, communication needs, and any reasonable adjustments that were required when she was accessing, say, the acute trust, for example. However, there were issues of that being utilised in the different services when she wasn't in the home, and actually the hospital passport wasn't always kept fully up to date as well. So again, best practice that needs regular review. So it's particularly if we know somebody's going to be accessing day services, treatments, GPs into the acute trust, it's really key for those reasonable adjustments to be met and to be aware of that hospital passport is absolutely key. And I know in our local trust, that's uploaded onto our Lorenzo system, which is at the hands of everybody who has contact with individuals with a known learning disability. So it's a really good piece of work to have to spend time on, really, and to use to its full potential. Hospital discharge planning arrangements did not always manage to fit with the community resources which were available for Adult B, leading to her being discharged from hospital before arrangements that actually could be appropriately made for her to be cared for at home. This is obviously a really concerning element to probably people listening in onto the discussions today, but this happened. And for those people involved with the direct care of Adult B, they were really concerned about this element as well. Another area which needs to be improved is around the specialist community dental service. So Adult B had a long-standing issue where she couldn't then attend her appointments. There's lots of discussion within the report around more could have possibly been done to communicate with the supported living service, to consider home visits, phone advice and support. However, the community dental team did carry out home visits, but it was only when urgent issues arose when they were requested to do so. So again, always responding to crisis rather than trying to have a proactive approach. And so what they have done is adopted that proactive approach to missed appointments, and they have implemented a follow-up arrangements for vulnerable patients who aren't able to attend. So that just kind of gives you a little bit of snippet of some of those issues which have been reported in the report, and the learning from Adult B, and the improvements which have already been made for, which again is really positive. We just need to ensure this is shared wider than what that one particular area, you know, to be shared across Cumbria, really, and that's kind of some of the point of today's discussion. So if we can just go on to the next slide, please, Colette. and you still with me? We're trying to admit Sarah here. I'll just close her down here and I'll just let somebody else look out for her. So the other area and issues which were identified in the report was around the assessment and funding of care needs. So there was lots of areas which went wrong in this particular aspect for Adult B. So she was subject to funding reviews and support plans with the local authority and through continuing healthcare, which is provided by the NHS. However, these arrangements didn't always appear to work together effectively to provide that optimal provision and resource for Adult B, which we've to ensure that she received adequate care. And this again was due to some lack of understanding and feeding back into that lack of coordinated approach and the lack of escalation of concerns from agencies. So following her deterioration of her health and well-being, which started back in 2015, about concerns around her funding were raised to adult social care via the supported living services. So these requests for additional funding went into the local authority funding panel via her social worker. However, she wasn't accepted on various occasions for additional funding. So eventually what happened to the supported learning service, they had to give notice as they were unable to provide Adult B with the care that she required as her needs became more complex, requiring a greater level of nursing support, which they couldn't provide within their tenancy. So having cared for Adult B for around 30 years, the care team did try to continue to look after Adult B for a further 7 months before they had to actually give up formal notice of their intention to. They did then have to terminate their contract to support her. An alternative care provider was found, and there was a really good effective handover between those two particular services across a 4-week period, which demonstrates really, really good practice. However, sadly, it soon became apparent that the new provider weren't able to meet the appropriate level of needs and support, again within the funding arrangements which she was currently receiving due to her increase in care. So they then also subsequently had to give notice of their intention to withdraw then the placement for Adult B while she was an inpatient in hospital. So she's now in hospital. A CHC checklist was completed, which actually indicated that she was entitled to fully funded nursing care at that point. So it's taken her having to go into hospital for her care needs to be appropriately identified. She was then discharged into the community, into a nursing unit, and then they were going to look at a nursing placement. But the difficulty that the care provider had getting to the point, you know, of health coming in and reviewing and assessing her care needs to say, actually, yes, she has got higher level of needs. She needed a further funding, change of placement. It took a further delay period, which again is just really difficult for the team who was trying to provide that wraparound support for Adult B's needs. So who is responsible? So local authority has the duty to manage and review care and support plans covered under the guidance of Section 27 of the Care Act. And then from the health side, funding of care and support can be the responsibility of both the local authority or the NHS via the CCG when she does when an individual is assessed as having healthcare needs. But there were so many disagreements between health and social care professionals around Adult B's eligibility for that continuing healthcare. You know, the lack of understanding of the funding process further frustrated practitioners involved with the care. However, there is now a joint dispute resolution policy which is in place, so hopefully that is helping to reduce the number of cases where we're seeing this as a particular issue. And what the process should have looked like, it should have included those timely reviews to ensure all people with a care and support plan had the opportunity to reflect on what's working, what isn't working, and what actually needs to change. And it ensures that plans are kept up to date and the relevant people who provide confidence and helps to mitigate risks of people entering what we've seen here in this particular crisis situation. And then the review process should have been person-centred and outcome-focused, as well as accessible, proportionate, to ensure that adult B's needs were met. But we've also seen none of that happened in this particular case, sadly, for adult B. So over to you, Colette, and supporting staff element.
Thank you. So one of the issues that came in the report was around the. Oh, I'm getting a lot of echo. Is everybody on mute? Sorry. Lovely, that's better. So around the long-term absence of staff and cover being needed during those periods of time, not only for the impact that has on the staff that are there, but also in terms of continuity of care and patient safety. And managing workplace stress, as I'm sure we all know, remains a challenge for all agencies and a dilemma for the supported living services as well. Now, several of the carers for adult B and practitioners at the learning event said that they found caring for adult B emotionally stressful. And I think from what we've heard today, we can absolutely understand why. And that they'd spent time caring for adult B when she was obviously in pain and unhappy. The impact of that was that the staff had felt helpless and emotionally drained at the end of each shift. Some of the staff ended up going off on sick leave with work-related stress, and other staff left their jobs because they didn't feel that they could continue to deliver the care that was required. Staff said that they sometimes felt they were letting adult B and co-tenants down because there was not enough staff time to go around everybody. And balancing workloads with resources will remain a challenge in today's environments of austerity. And ensuring staff have regular supervision and debrief is really important to maintain the employee-employer relationships and understand the challenges of those that are caring for people with complex needs and the everyday stresses of delivering that care. The implementation of the escalation policy can also help support staff when caring challenges become too great, because this will provide a clear pathway to raise concerns with management and escalate beyond line management if needed. Most of the participants at the learning event reported that they had up-to-date training in safeguarding mental capacity and best interest, and that there was a commitment for this level of training uptake to continue. And that's really, really positive, because obviously staff that feel that they've got the knowledge and resources to manage in these types of situations are hopefully going to feel more able to continue to stay providing that role. Now, the next thing that we really wanted to make in its own right really is around the good practice that was seen for the people that were involved with adult B. And the review really highlighted a number of good practices, and we really want, as I say, want to recognise these today. It was said that on an individual level, the carers showed tenacity, compassion, care and support to adult B, and that it was an established, consistent team who knew her well and who she was familiar with. This is really important, as any change of staff can easily increase anxiety. The supported living staff spent periods of time at the hospital supporting staff to get to know adult B and how best to care for her based on all of their years of experience of looking after her. There was a really excellent handover of care between the supported living services, as Kelly mentioned earlier, when there needed to be a change of provider. The report also mentions that the community learning disability nurse worked hard to ensure that communication and information sharing took place across the different services. And the staff at the learning event felt that this was a consistently supportive factor. So a lot of good work obviously went on within Adult B's care as well. I'm just going to hand back over to Kelly, who's going to give probably a brief overview. So we've just got 15 minutes left of Cumbria Safeguarding Adults Board.
Yeah.
Thanks, Kelly.
So no worries, thanks, Colette. So these next few slides really is just to bring your attention, if you haven't already had access to the Cumbria Safeguarding Adults Board, it's a really good resource and tool for practitioners to use, you know, for guidance support. And it's going to be under development, so there will be a learning zone which will be incorporated for resources to be accessed, etc. And essentially, you know, the purpose of the board is putting individuals of Cumbria at the heart of what we do. What we're trying to do today is bring to your attention where things have gone wrong, but absolutely what we are trying to do to, you know, in order as board members to put things right across the system, learn from particular issues that we've come across and faced today, and just listening proactively to the agencies who were involved, and try to improve and share and learn from each other, really. So that's the sole purpose of what the board's to do. We're here to protect our population. So if we just move on to the next slide, just to bring to your attention, if you haven't used them before, there's a range of different tools and guidance available for you to access. One of which is, it's quite still fairly new, threshold tool in order to support individuals raise a safeguarding inquiry into the local authority. It can be used across all different agencies as a really good tool to provide a consistent approach to raising concerns which you might be coming across the system under the safeguarding processes. So it's a support decision making tool, and on the particular link on the other side, you can access the threshold tool there under the professionals guidance. Thank you. If we just move on to, so what's included in it, as a really brief overview, it includes all the different categories of abuse which are defined in the Care Act 2014. And in terms from a health and perspective, for example, it looks at falls, pressure ulcers, medication areas, service user on service user incidents, just to name a few of the different categories which are available for support and guidance on. So if we just move on to the, don't expect you to be able to read that there. This is just to give you a bit of a visual of the system and how it would work. So it would it details the types of abuse. So in this instance, it's around physical abuse on an individual. It gives you the traffic light system of lower risks, medium risks, and high risks, examples of what fits into each of those different criteria, and then just at the bottom around outcomes for consideration at each of these different stages. So again, it just helps to support and advise you really as to when you should be making a referral or inquiry into the local authority, or what you can do locally in terms of making sure you have mitigated any further risks to an individual, and whether or not it meets the threshold to progress further under a Section 42 under the Care Act. So that's just to give you a visual of what the actual threshold tool looks like. Hopefully you're all familiar of how to raise a concern. Within the pack, obviously, you will have access to the different contact numbers detailed there. If it is an emergency, you phone 999, obviously. There is the emergency duty team, out of hours team, if you do need advice or support, obviously, for safeguarding. And those are the other contact details. And I must admit, since safeguarding has worked back in each of the locality areas now, there are specific teams for the different areas. The response to safeguarding concerns has never been better, from my opinion and my observation, you know, working within the safeguarding arena for many, many years now. So that's how to raise a concern. If we just go on. Oh, that's back to yourself, Colette, at the moment.
It is. So just to, again, just a brief whistle stop of information sharing guidance. So in Cumbria, we have got an information sharing agreement, and it's been agreed by the statutory partner organisations. And the guidance is intended to summarise the key elements of information sharing when working with adults at risk of abuse or neglect. And it also aims to increase the understanding of the basic principles of information sharing, particularly in relation to safeguarding practice, and sharing the right information at the right time with the right people, which is absolutely fundamental to good practice in safeguarding. And it's often highlighted as a difficult area of practice. And you can find the full document via this link again here. So throughout the presentation, anything that you see that looks like a link should be a link, all being well if technology has worked. So you can have a look at that as well. And then just a bit of a refresher. I mean, you're all professional people, just some of the reasons why we share information and some of the real positives that can bring in terms of coordination of services, maintaining good practice, various factors, identifying low-level concerns, reducing organisational risk. And just to remember that GDPR is not a barrier to sharing information. I think often people get a bit worried about sharing information, but it actually provides a framework to ensure that information is shared appropriately. And just some tips there around what makes good information sharing. So around being open and honest with the person from the beginning about why, what and who you're going to share information with, to seek their agreement. And if it's not safe or appropriate to do so, there are obviously situations where you are able to share that information anyway. Seeking advice if you've got any doubt about disclosing any information, and sharing with consent where appropriate and where possible. Respect the wishes of those who do not consent to share confidential information. You may still share information without consent if your judgment suggests that you need to. And again, you are all professionals here today, so I'm sure this is very familiar to you. And just that reminder that information sharing should be necessary, proportionate and relevant, and recorded as well when you do so. Yeah. I think that just takes us to the conclusion, Kelly.
Yeah, so just to summarise really, and some to close the presentation, to summarise the review of Adult B. So the findings of the review was shown that multi-agency systems and processes in place during the reporting period didn't meet the needs for Adult B. So Adult B who had learning disabilities and complex care needs, they weren't sufficiently coordinated to comprehensively manage the situation. This resulted in the delay in her receiving effective treatment and adequate care planning to manage her multiple needs. So professionals caring for and supporting Adult B did so with care and compassion. So the learning from the sad death of Adult B will ensure that future agencies work more effectively together to particularly improve outcomes for adults with a learning disability. So that's kind of just some closing words really on this particular presentation, and our contact details will be on the next slide, but there's links there in terms of taking you through to the Adults Board. And absolute thank you to everybody who's been on the session today. Hopefully you found it informative and useful for practice, and if you do have any queries, you can contact Colette, myself, to discuss any of the areas further. So thank you very much, everybody.